Good evening, everybody. I think we'll get started. Thanks for joining us. My name is Adam Shikadans. I'm a general pediatrician and chair of the American Academy of Pediatrics California Chapter 2 ACES Committee. And you're joining the ACES Aware Peer-to-Peer Learning Series, our first webinar. Thanks for joining. I'll just say up at the top that the AAP California Chapter 2 is really pleased to partner with First 5 LA to implement this first of a series of 4 peer-to-peer learning sessions. These sessions are supported by California ACES Aware as a provider engagement activity to raise awareness, the impact of childhood adversity on health throughout the life course, and what we can do better to address childhood adversity. The ACES Aware initiative, for those who aren't familiar, is an initiative launched by the Office of the Surgeon General in California, the Department of Healthcare Services, with the aim of reducing adverse childhood experiences, or ACEs, by half in a generation. Let's go to the next slide, please. Here's our agenda for the evening. We have from now until 7:30 to cover a fair amount of ground. We're excited to do that with you. In our agenda, we'll do some quick welcomes, which we're already into, and then we'll hear from Dr. Christine Tang on ACEs science and the physiology of toxic stress. Dr. Tang will facilitate a question and answer after her comments for another 5 minutes or so after the initial 25-minute presentation. And then she'll facilitate a clinical case study for another 5 minutes, just reading through the case study. We'll then dive into the case study in much more depth in breakout rooms. So we'll be creating Zoom breakout rooms for everybody to join at that point in the webinar from 6:45 to 7:05. And then we'll come back, and from 7:05 to 7:25, Dr. Tang will facilitate the idea share from those breakouts. And we'll get into the details of exactly what we'll cover in those breakouts when we get there. Finally, we'll spend about 5 minutes on closing and evaluation before we wrap up at 7:30. I'll just note that the meeting packet, including an agenda, bio, and slides, bio for our speaker and slides, will be shared in the chat. So look out in the chat for that. It's also worth noting that the PDF in that packet is bookmarked, so you can navigate to any section of the packet, including the slides, the case itself, and other aspects of the presentation just by clicking on the bookmark on the left-hand side on the ribbon. For those who are planning on and interested in getting CME credit for their participation tonight, please note that you'll need to attend the entire session, including the breakout discussion, and complete the post-session survey to be distributed later before you can receive your CME credits. Next slide, please. Some Zoom etiquette just before we get started, so we're all on the same page. Please mute yourself before entering the Zoom call and unmute yourself before you speak. If you're joining by phone, you can press *6 to unmute yourself and *9 to raise your hand via phone if you have if you're interested in making a comment. Add your organization to your name in the participants list on the right-hand side by hovering over your name and renaming, clicking on the rename option. Also, feel free to use the chat throughout the meeting. We'll be monitoring that closely. So if you have questions or concerns, technical issues, please drop that in the chat and we'll be responding throughout the webinar. Also, join us on video if you can. We'd love to see your faces and be able to participate in a more sort of real-time way through the video. It'll also be really helpful during the breakout rooms so that everybody can see everyone else engaging, and we can have a more sort of live experience. Without further ado, I'll introduce tonight's speaker, Dr. Christine Tang, who's an assistant clinical professor in the Division of General Pediatrics at UCLA. She's an experienced expert in training clinicians to be trauma aware and responsive. She's an expert trainer on the American Academy of Pediatrics National Evidence Informed Curriculum. Next slide, please. And she's also the Pediatric Approach to Trauma, Treatment, and Resilience pattern program trainer, and has done trainings with that National Evidence Informed Curriculum from the AAP. This curriculum has been adapted and piloted across disciplines and levels of training, and we're delighted to have Dr. Tang sharing some of this curriculum today as part of today's session. Dr. Tang, over to you.
All right, thanks, Dr. Shanidans. Hi, everyone. I am Christine Thang. I am a general pediatrician, as mentioned, and I am thrilled to be here talking to you all about ACEs science and the physiology of toxic stress. So let's get into it. For disclosures, I don't have any relevant financial relationships to disclose. There's not much in that realm. And then this session is part of an ACEs Aware peer-to-peer learning series funded by an ACEs Aware grant to First Five LA. With that all being said, I think I'd be remiss not to give a moment and give pause to the events that happened yesterday. Like many of you, I too was deeply shaken by what we witnessed in our nation's capital. So I do want to say thank you to everyone for coming together and joining for this ACEs Aware event. So a little bit will be taken from the Pediatric Approach to Trauma Treatment and Resilience. This is the PATTER project that's being given by the American Academy of Pediatrics. This is a joint effort from the AAP, the University of Massachusetts, and UCLA with an educational grant from the Substance Abuse and Mental Health Services Administration. Dr. Morris as many of you might know, is the AAP president-elect, and she serves as the principal investigator for this project, in addition to Dr. Heather Forkey. So you will see some material from there. So for the learning objectives for us in these short 25 minutes together, by the end of the session, we'll be able to talk about the original Adverse Childhood Experiences, or ACEs study, to describe how toxic stress impacts 3 physiological mechanisms, to identify variable responses to toxic stress depending on our patient's age, and then to examine how toxic stress physiology relates to a pediatric clinical case. Some of this you may have already seen, but to get everyone up to the same speed, the original CDC Kaiser Adverse Childhood Experiences study. So this was a study that was conducted with adult patients in the Kaiser Permanente network down in San Diego in the 1990s. So these were 17,000 adult patients, and these patients completed confidential surveys regarding their childhood experiences and their current health status and behaviors. Over on the right side, what you see is the original 10 ACEs that were covered in the study. So these covered the domains of physical, emotional, and sexual abuse, neglect being physical or emotional, and then these household challenges. These included growing in a household with a caregiver with a history of incarceration, mental illness, substance dependence, who were absent due to separation or divorce, or intimate partner violence. I think a lot of times adverse childhood experiences, or ACEs, are used in the same sentence, whatnot, with social determinants of health. But we have to remember that these original ACEs were really in the realm of intrafamilial traumas, right? These things that sort of played into that family unit and had an impact on that family unit. So we think of these as intrafamilial traumas. From the Dr. Anda, a co-principal investigator to the ACEs study, what we find is that ACEs are common. They tend to occur in clusters rather than single experiences. And the cumulative impact of multiple exposures can be captured in an ACE score. And that's what we're focusing on. And that ACE score likely captures the cumulative neurodevelopmental consequences of traumatic stress. And the ACE score has a strong graded relationship to numerous health, social, and behavioral problems throughout a person's lifespan. I think many of you have seen the charts where there's this dose-dependent response, where the higher the ACE score, the higher prevalence of these negative health outcomes in adulthood. To bring that home, we see that ACEs dramatically increase the risk for at least 9 of the 10 leading causes of death in the United States. So when you think about heart disease, cancer, accidents, lower respiratory diseases, stroke, Alzheimer's, diabetes, this list that we see very frequently, you'll see that the odds ratio for when you have 4 or more ACEs, those are pretty high, 2 times, 3 times, all the way up to 10, 11, 40 times are the typical what's. And it's not too much significance that the association between ACEs and these negative adult outcomes. You'll see that they span the gamut from mental health issues to maternal health, infectious diseases, chronic diseases, even down to your opportunities, what you're thinking about in adulthood, your education, your occupation, your income, right? It spans the gamut of all these different outcomes. And then coming from the adverse childhood experiences study, we know that that was that abuse, the neglect, the household dysfunction. We look into what is the impact on child development, right? We know that the original ACE study was done in our adult patients. You It's hard to apply causation, something that's not a randomized controlled trial, and you essentially see this association. But what was happening to childhood development? What we see is that there are neurobiological effects. We'll go into a little bit about that as we go into the physiology. The psychosocial effects, as we mentioned, poor attachment, poor socialization, poor self-efficacy, to the health risk behaviors. And for those of you who are involved in health services research, a lot of what we're studying in those domains are those long-term consequences. So you see the disease and disability and the social problems that all stem from that. What we also look at is how stress plays into all this. Some of you may have seen this chart before. If we start up on this end, it's not to say that all stress is bad. And we know that on that positive stress side in that green, stress is a normal, essential, healthy part of healthy development. There's that brief increase in heart rate and in blood pressure, that mild elevation in your hormone levels. You think back to when you're studying for your licensing exam, or your MCAT, or for those athletes getting ready for that playoff game, you need that brief elevation in your stress hormones to sort of get things going, right? To get things revved up. And then in the middle section in our yellow, that's our tolerable stresses. Our body is equipped to handle those. So your body's alert systems is activated to a greater degree than that positive stress section. That activation is time limited and buffered by caring adult relationships. So when you think back to those examples that we have here, the death of a family member, being involved in a car accident, there are those buffering relationships, those safe, stable, nurturing relationships that sort of help you get through those instances. And then on the far end, on the side that we look at the toxic stress in red, well, that occurs with your strong, frequent, or prolonged adversity. It's that disruption in your brain architecture and other organ systems, and you have that increased risk of stress-related diseases and cognitive impairment. So again, those examples that we recently just seen is that abuse, the neglect, the caregiver substance dependence, the mental illness. So this is where on one end you have that toxic stress. When we stack them all up against each other, it's pretty a lot more easy to see what exactly that difference is we're looking at. And it's really that prolonged activation of your stress response system, that absence of your protective relationships. This is really what makes that stressor particularly toxic. The question then becomes, what does trauma look like in children? I think many of you would be like me when you think back on your medical school training. What we learned about stress is typically thinking about that soldier coming back from war, thinking about your internal medicine rotation in your Veteran Affairs Administration. But what we see in children isn't that stereotypical stress response. It could be that child who is with the flat affect, is disconnected, just sort of seems disengaged, to the child who has those frequent tantrums, who is often described as just a little bit off. They're short fused, they're easy to get riled up, and no one can exactly figure out why, to those that may be at risk for already involved in the juvenile justice system. So it's sort of not as stereotypical as we think compared to the traumatic stress that we've learned before. Similar to how we do things in medical school, the approach that we take is trying to understand what's happening on the inside to see what's that clinical manifestation or what you see of that patient before you're in the clinic. So we know that toxic stress triggers potentially permanent changes through 3 different mechanisms. And the 3 mechanisms that we'll look at here is the neurobiology, the immunology, and the epigenetics. So starting with the neurobiology, we'll be taking you back to your first 2 years of medical school, thinking about the hypothalamic pituitary adrenal axis, your Hpa axis. So the system is activated by stress. You have that peripheral release of cortisol, and it stimulates multiple areas of the body and the immune system. We oftentimes use the analogy of stress in the tiger to explain our Hpa axis because our bodies are designed to respond to stress. Your adrenaline and cortisol help us run from the tiger or choose to hide it from it. That duration of threat is short. Again, it's time limited, and it's that fight or flight response that we're thinking about. But then what happens when this tiger or this trauma lives in your home or lives in your life and you're constantly or chronically exposed to it? So thinking back on that Hpa axis, I'm sure you guys are all thinking about that in your mind. Well, like every other axis in our body, there's that negative feedback loop that exists. So with the HPA axis, you have that peripheral release of the cortisol. It's doing what it's supposed to do for you to choose to either fight or flight from that tiger. But when you're exposed to that significant trauma or that adversity, what happens is that your body is no longer at the state to be able to fight off infections, let's say, right? You're sort of existing in survival mode. And your body is smart. What it does is that your gene expression will also be altered, as it should, because you're trying to adapt to what's needed constantly. So when we move from our HPA axis to what's happening in terms of neuroanatomy and looking at functional MRI studies, there's a couple of brain areas that we know are particularly impacted. So one lower brain area is the amygdala, and we think of this, I'm not a neurosurgeon, but just simplistically, that the input is for sensory memory, it's our attention center. Think of it as your emotional memory system. For this purpose, we sort of equate the amygdala to that of your brain's alarm system. So if you think of this child who's constantly exposed to stress, what do you think will happen to that amygdala? And in your mind, if you're thinking that, well, that amygdala is going to be revved up, it's going to light up in those functional MRI studies because that's your brain's alarm system. It's ringing off the hook and letting you know that there's danger nearby, and it's sensitive to these dangers because there's this tiger who's existing before you. Neighboring the amygdala, we have the hippocampus, and it's the interface between the cortex and lower brain areas. Its major role is in memory and learning. What helps me remember it is that it's sort of our brain's filing cabinet. It's the search engine, whichever search engine it is that you like to use. When you think about the hippocampus in the setting of being exposed to constant stress and trauma, well, this filing cabinet or this search engine really can't be prioritized. So if anything, you're sort of thinking as your hippocampus is actually offline. It's atrophied. It's not as turned on as your amygdala, because things like learning and memory are only able to occur when you're safe to do so. So if you have that tiger in front of you, you're not going to have the opportunity to think, is this an Asian tiger? Is this an African tiger? Is this tiger endangered or not, right? You're really focused on your survival. The next area is our prefrontal cortex, and this is your executive function area. It's in charge of impulse control, working memory, cognitive flexibility, thinking from being exposed to toxic stress and trauma. This, again, is not prioritized because you don't have the opportunity to think rationally. You want to, if anything, react to the situation instead of using your impulses and your cognitive flexibility. And then the fourth and last area that I'll look at in terms of our neurobiology is your reticular activating system. And this neural network controls your wakefulness. I think it goes without saying that sleep is oftentimes sacrificed in the setting of being exposed to trauma because you're really not in a safe place to do so. So taking everything that we just went through, we talked about our HPA axis, where you have that peripheral release of cortisol that's constantly on, your amygdala, that alarm system is on. You don't have that time capacity or space for your memory and learning, and you have your prefrontal cortex that's offline. When you take that all together, what's happening on the inside, then we start to think, well, then what does that child look like before us? And when we look at that, similar to other realms that how we study pediatrics, is that it's sort of age dependent, what you'll see. So in this first row, when we look at that infant, toddler, preschooler, the school age child, the adolescent, across the domains of your working memory, your inhibition control, and your cognitive flexibility, what you see is that infant, toddler, preschooler, that might be the child who's having some difficulty acquiring their developmental milestones. It also is that child with those frequent severe tantrums. They may be showing aggression with other children, and their attachment to their caregivers might be impacted. And then in terms of their cognitive flexibility, they're easily frustrated. For your school age child, because you have that setting of school to sort of be another historian, what you'll see is the teachers might report that they have difficulty with school acquisition. Where we talk about their losing their details can lead to confabulation, being viewed by others as lying. Well, we said that when your hippocampus is offline, your memory and learning is impaired. So you may have some gaps in your memory because of this. And for a child who's constantly being asked by whether it's the teacher in their life or their physician, their social worker, whoever it might be, what happened, they have difficulty remembering these instances. But when you have adult that frequently keeps asking them this question, they feel like they need to fill in those gaps, right? And those gaps might not be exactly be the truth. And here they get perceived as lying. In terms of inhibitory control, they're frequently getting in trouble in school, they're fighting with their peers, they may be disruptive in class. And oftentimes what I'm describing may be misdiagnosed or maybe improperly diagnosed as simply ADHD or a learning problem. And then you'll see those organizational difficulties. For the adolescent, again, they're having trouble keeping up with their academics. They may be getting in trouble at school, at home. Again, that confabulation, the integrity issue comes into play. And then their impulsive actions now start to threaten their health and well-being. And those actions that they're doing may start getting them in trouble with the law. And those tasks of young adulthood, which requires that rapid interpretation of information, they may have trouble driving and holding a part-time job or functioning in the workforce. So this is sort of that child that we're seeing at the different ages. And again, when we put that all together, what we see is that what becomes prioritized in this instance is your limbic system, that amygdala in particular, right? Your brain's alarm system. And those skills of survival are what is really weighted and prioritized. And your higher brain functions, that cortex, that skills that are dependent on attachment, having those safe, stable, nurturing relationships, that safety, well, that really gets less prioritized when you have this side that's being weighted down. The other two sections that we'll go over a little bit quicker in terms of the immune system, well, those immune consequences also stem from that peripheral release of cortisol, the chronic cortisol exposure, and you have suppression of your immune system. Inflammatory pathways get upregulated, they're no longer responsive to that cortisol, you lose that negative feedback loop. And then there are some subsets of depression that are also inflammatory mediated. So then you see that mental health those implications come out. And then that developing system is chronically pressed into action. So this is where you have that excessive cortisol suppressing your humoral immunity. You have an increased risk of infection. Your inflammatory response persists long after it's needed. And then your somatic perception is impaired. So those vague abdominal pains, those headaches that you can't quite figure out what's going on. And the last area is in the realm of epigenetics. And that's not so much how the genes are altered, but really how your genes are expressed. And in some animal models, what you see is that if you had a pup that's raised by an anxious, low nurturing mother, this pup grows up and becomes an anxious, low nurturing adult. And then you have those pups that are raised by a relaxed, high nurturing mother, and they become a relaxed adult. And I include this because what's interesting is that if you take these pups that are raised by these anxious, low nurturing mothers, and then give it to this mother, this pup actually has the potential to grow up also to be relaxed and high nurturing. So then it comes into when we talk about nature versus nurture, not everything is black and white. The bottom line to all this is that the significant adversity that's experienced, that toxic stress, right, even those adverse childhood experience, it results in less than optimal outcomes later in life. But that's not to say that you can't change or you're not able to mitigate these factors so that you don't have these negative outcomes later on. So when we think about trauma responses, they're oftentimes, we know that they're adaptive and protective when in threatening situations, right? When we looked at the different organ systems, when we look at how our body is equipped to respond to stresses, it's doing what it's supposed to. What happens is that these same bodily functions and behaviors, they may be actually perceived as maladaptive when the child is removed from the stressor. And then when we don't examine this in the context of past traumas, we start misinterpreting these behaviors, these actions that we see as pathologic. What happens is that many of us are trained to think of our patients from a problem problem focus, right? What is the problem list? What can I do to fix it? But really it's trying to shift our framework from not just what's wrong with you, but instead really what's happened to you, right? How can I understand what's happened to you? How can I understand those buffering, safe, stable, nurturing relationships and really bolster those to help mitigate the toxic stressors that are ongoing? From the PADA curriculum, what we use is that if we take a strength-based approach, what we're looking at are the resiliency skills. And these we call the threads of childhood. And I think for many of us, when we think about children and what makes them resilient, we think about their thinking and learning brain, how they're hopeful, having that regulation or self-control, wanting to be self-efficacious, their attachment, being able to have that developmental skill mastery and that social connectedness. Well, these are the skills of resiliency in kids, and these are the things that we're trying to bolster or weave as the threads of their childhood. What happens with trauma, though, is that all the opposite becomes true. That late thinking and learning brain we see shuts down. Their ability to look ahead, to be hopeful is lost. They lose their ability to regulate. They're no longer efficacious. Those safe, stable, nurturing relations, they don't feel as safe anymore. We see how their developmental skills are lost and their social connectedness, they feel as if they're alone to deal with the threat before them. So when we take the opposite of threats, what we have is a child who's frayed. And using that same picture in our minds, this child is frayed and at the end of their rope. And what you see are these frayed symptoms, the fits, the frets, the fear, the restricted development. There is attachment concerns. They're yelling, they're yawning, they're having poor sleep, they're throwing frequent tantrums, those educational delays that we see in the school, and they're defeated, they're dissociated, that hope is lost. So that's a brief tour of the pathophysiology of toxic stress and using the FRAID and the threads acronyms to sort of put all that into picture. If you are interested in more training, the course that I mentioned is the Pediatric Approach to Trauma Treatment and Resilience course. A couple of us on the ACEs Award Committee have been involved in this as well too, so I included this here. And then with that, I sort of take a pause, leave room for questions. And then if you want more information on the AP California or our ACEs committee, you can certainly visit our ACEs site. Thanks, everyone.
Thanks, Dr. Thang. So this is a great moment to either raise hands or put questions in the chat if you have them. So Stephanie Booth writes and asks, can you develop resilience without having stressors?
I think that you can still develop resilience. Whenever I think about resilience, I think of Ann Matson, who wrote a book called Ordinary Magic about it. And it's sort of these traits that the children have inherently. And that's sort of how we came up with that threads mnemonic. So even if they're not exposed to those stressors, those are the traits that we find are universal and worldwide among children and sort of the foundation for resiliency for them.
We do have another question. Harsha Sheth.
Yeah, this is Dr. Sheth. Yes, right now, at least in my office, I'm seeing the patients only well babies and not seeing any sick kids as much. So right now, definitely we have time to go behind the scene and talk about all these stressors. And typically my question to the teenagers is like, what is one plus thing you like about COVID and one minus thing you like about COVID? And you know, that's how I start with teenagers at least, or even the young kids. But once the regular flow of pediatrics starts, and you know, when we are seeing more patients and in the clinic, I would love to see 20 patients and you know, answer everybody and go about the ACE screening and go in detail about positive reinforcement and positive life. And of course, I think we are going to talk about this later, hopefully. But I was thinking, should I hire the psychologist in the office? Or the other thing is also, I think pediatrician knows a lot about the families, so I think we can help them more rather than psychologists, because we know where mother works and how mother's schedule is, or she's a teacher, or she's a PA, she's a physician. But so I think we are the one which can help a lot to them. But the time factor, and which you can help us or send the email, and where we can start working on it from right now and continue till by the time we finish the last chapter, we all have that information.
Yeah, and I encounter that a lot too when I precept the residents in their continuity clinic. You know, they're trying to learn how to do well child care, and they're, you know, they have patients lined up, but they also have to staff with the attending, and they're like, you know, how do we do all this? And sometimes what we talk about is, you know, a lot of it is surveillance, right? So, you know, beyond just the screener, you know, even asking a simple question of a family that you see that may be bringing up some of those braid symptoms is the question of, you know, since the last time I saw you, has anything scary or upsetting happened? Right. And it sort of just leaves the door open depending on the age, whether it's a child or a teenager, you know, what they perceive as scary or upsetting to them.
Yeah, I mean, that's a very good question, that if something has happened to you from the last time, you know, and also like if last time, if mother has said that, oh, we are in the process of divorce, so next time when they come, you ask them how is things at home. But I think it's difficult for the child to open up that fast with that question, because generally kids won't open up that, okay, you know, somebody died or somebody, kids won't, and then mother might not want to talk about it, and you know, so but I think that's a very good question, that if anything changed since last time, and probably that might open up the whole conversation.
Yeah.
Thanks.
Thanks,
Thank
Dr. Shet. I'm seeing a lot of great questions in the chat about practice changes and resources to address adverse childhood experiences, which is exactly where we're heading in future webinars in this series. So I hope everybody who's tuned into this one will stay tuned to future webinars. Next time we'll be talking about practice changes and addressing barriers, and also incorporating resources to help us address adverse childhood experiences in our various practices and settings. I think we have probably time for one more question before diving into the case. And one that I think a bunch of folks might have is, Dr. Thang, would you tell us a little bit more about where to find the further training, the pattern training, how people can access that?
Yeah, so I apologize. I realized that I didn't include the link here. If you go into the American Academy of Pediatrics website and just, you know, even in your Google search engine, Pediatric Approach to Trauma Treatment Resilience Pattern, you'll be able to enroll. And it's a 6 weeks course. Each cohort is able to sort of pick what day works for them, and it's once weekly over those 6 weeks. And some practices will have their office participate, so it's not just physicians, but you're able to include your office team in that as well too.
Fantastic. Thanks for addressing that quick. I think we can take another question or two. So I see a question in the chat, and Dr. Teresa's let me know if there are folks who have their hands raised who have been waiting for a little bit longer. But the questions that I see in the chat that pertain to this session's topic would be one such as the question of pruning, and whether if you don't intervene at an early age, there are opportunities to address some of the consequences of ACEs psychologically and physically, or if you've missed the boat, if you get out of that early childhood critical developmental window and are encountering a child, say, in the pre-adolescent phase or in their adolescence. How do we think about early intervention versus late intervention, whether one is more effective than the other?
I would say that I don't know the specific answers to that exactly. I don't know if you might, Adam, but I'm thinking that when we think about pruning, we usually think about the early childhood period, right, and how critical that is. But I still think that that plasticity would exist into adolescence as well too, probably young adulthood. And sort of after that, when you have everything developed, right, like that prefrontal cortex and whatnot, then you may be a little bit more amiss.
Mm-hmm. Yeah, these are questions that don't have obviously a single answer and will depend on the case in front of us in every instance. But certainly the evidence would suggest that there's quite a bit of room for for progress and recovery after adverse childhood experiences experienced early in life, even if you're intervening in later childhood, adolescence, and maybe even into adulthood. It's been great to see some questions about resilience in the chat, and this is an area where there's a lot of active research being done. We don't have perfect answers about when and how to intervene to increase resilience and address ACEs, especially later on in life. But the preliminary evidence at this point certainly suggests that introduction of resilience factors and positive experiences just about at any stage in childhood can be beneficial. Also bring people's attention to the link to the pattern training that was just dropped into the chat. Okay. Any other questions before we move on? If not, let's talk through the case and then we'll go into our breakouts.
Great. So this is a case we just wanted to be able to have everyone talk about a similar case and sort of have that as our foundation. So this case is brought to us from one of our ACEs committee team members, as Dr. will say. And this is, well, I should also say that this information was gathered over a couple of visits, so please don't feel like this was all gathered in one clinical encounter. But we have a 12-year-old boy, we'll call him Henry, who comes in with his mother for a well child visit. Mother has no concerns today. She says that we are here for his annual physical and his shots. You know this patient pretty well. He had asthma diagnosed at 3 years of age. It's been fairly controlled. He only needs and has an albuterol inhaler as needed. However, sometimes he misses school because of wheezing episodes. There's no known drug allergies or medication allergies. You do your social history as you do with all your teenage patients, and you know that Henry resides with his mother and his maternal grandmother. There's occasional contact with his biological father, who's now remarried and has another child. And then when you do your teen confidential history and ask Henry about his father, Henry says that, I feel unloved by my father. There is no point in being alive. He's been very sad because he lost his best uncle 2 years ago after witnessing that assault. And this uncle was like a father to Henry. He's worried that his mother will die too. And he's happy to have his grandmother and mom in his life who care deeply about him. He has no health concerns for today's visits. And like most teens, he sort of shrugs his shoulders when you ask him about school. When you ask his mom reports that Henry struggles with his 6th grade schoolwork. Mom says, if he only got off those video games and paid attention, he would do better in school. When questioned directly, Henry reports, I don't get math and the words don't make sense when I read. School is boring. Henry confides in you that he's in his 3rd school and the kids always pick on him. He barely speaks to anyone in school because the kids are mean and dumb. Video games are what makes him happy. And church, he says. He would like to study coding and programming in the future. However, he stays up until 2 a.m. playing video games most nights and really struggles to wake up for school in the mornings. When asked to turn it off, Henry becomes very angry and his mom says that he's threatened to burn down the house when she's asked him to turn off his games. Mom reports that she is tired of this behavior, but really sort of at her wit's end, doesn't know what to do. Mom reports that she herself lives with an anxiety disorder and has trouble sleeping if Henry is awake because she's worried about their safety. You review Henry's depression screen and it shows a high risk for moderate to severe depression. He denies alcohol or any substance abuse. The family history is notable for, that mom has general anxiety disorder, depression, pseudoseizures, diabetes, and hypertension. She had a cerebrovascular accident a few years ago, and that's affected her memory. The dad is otherwise healthy. The review system is notable for increase in weight and difficulty concentrating, but nothing else really stands out. His blood pressure is normal. His BMI is in the 99th percentile. He's been obese. His height's at the 75th. On your exam, he's calm, well appearing. He does, like most teens, he avoids eye contact and is playing on his phone throughout the visit. His psychiatric assessment shows that he does endorse some passive thoughts of harming himself in the past, but has never acted on this, doesn't have any plans. And the last time he had these passive thoughts was about 2 months ago. So I don't expect everyone to be able to memorize this case. We'll share it again in the breakout session. But some of the questions that we hope will sort of spur the ongoing discussion is thinking about how toxic stress physiology relates to the pediatric clinical presentation, the objectives using the FRAID and THREADS acronyms to better understand the trauma presentation resilience approach, and then to identify practice changes. From what Dr. Shakinaz was saying, it seems like many people are already starting this process in the chat box. So the questions we'll be looking at is using the FRAID acronym, what symptoms do you know among Henry and his mother? And then using the THREADS acronym, what buffering or protective factors, those skills of resiliency, do you know for Henry and his mother? And thirdly, how would you approach this visit today? How would you manage care for this child using the resources available to you in your current practice? What additional services or changes to your current practice would you like to make to optimally address the needs of your patient and family? And then what additional information or resources are needed to implement these changes? For this breakout, really see the strength in that peer-to-peer learning, right? Being able to connect with one another. And that's really the purpose for this virtual meeting that we're having right now. So I will hand it over to our breakout dividers.
There is a question about what depression screening was used.
Dr. Osei?
We used the PHQ-9, modified PHQ-9 for teens.
So we'll be, you should be receiving an invitation to a breakout room momentarily. Please click join breakout room when you see it. And we'll see you in the breakouts and then see you on the other side when the breakout time is out. Welcome back, everybody. Okay, so we have about 20 minutes. I think we have just about everybody back from the breakouts, hopefully, at this point. So we've got 20 minutes to debrief a little bit and talk about what we discussed in the breakouts. Dr. Tang, I'll let you facilitate this section.
Right, and it does sound like everyone was pretty in agreement that it went by a lot quicker than we thought. So that's actually good news. I'm really glad to hear that. So with that being said, I will open it up and see if anyone had anything that they wanted to report back from their group. Again, our questions were, one or two things that you found enlightening from your group, or any practice change that you're looking to have. And this is where our committee is sort of looking for some input in those areas too. So maybe I'll see if there's any volunteer who raised their hand or put something in the chat.
So I guess we didn't really do the practice change thing so much as try to figure out what we would do for him through the resources that we have. But I'll step back. The threads is kind of where we started, and kind of between fits, frets, and fear, and attachment concerns, and defeated dissociation. He's depressed. He's probably having a good deal of trouble making attachment with his remaining mother. He doesn't attach to his dad. His uncles died. He's worried that mom will die too, and she's got some issues. She had she's got anxiety, and she also has her cerebrovascular accident. And so who knows how much of this issue might be contributing, she might be contributing for his difficulties. He's really having a hard time with education. The things he likes, which if you want to go up to the hope piece of it, are his video games, which may give a little bit of social connectedness, as well as the church, which may give a little bit of social connectedness. But he's not good at education, so he probably needs to be evaluated for that to see if there's a real learning problem there. I mean, we can let somebody else go now if you want, because I can keep telling you what we got, but that's basically, I think, some of the major things that we decided were issues. Oh, and then one of the things we really want to do is get some more information, to see him back and get more information, because who knows, the video games maybe helping in social connectedness, and he may be playing some game alone. So don't really know on that. There's all kinds of stuff like that where we don't have enough information. So
Great.
I'll,
So your
I'll
group
step away
identified,
for now.
yeah, identify some of the afraid symptoms and I looked at areas for resiliency skills that you could probably work on bolstering for them. Great. Just want to confirm, we have 10.
Similar. That was kind of similar to our recommendation. We felt it was essential that he get a psychoeducational evaluation at the school, which should include also, typically also includes the emotional component and the possibility of getting some therapy through the school and trying to build on his interest in possible computer programming and seeing if there are resources at this point that might be able to use that as an entryway into other educational things that he's actually interested in. Again, agree that we need further opportunity to evaluate probably therapy for the depression and consideration of pharmacologic treatment of the depression if indicated, but would start with psychological. Well, you already have had a psychological evaluation, haven't you?
Yeah.
That found him depressed, yeah.
Mm-hmm. And then based on the summary that these two groups have provided, does anyone have any new ideas or something else that you would, when we talk about practice change?
If it's okay if I speak up, I was in breakout 7. One of the things that I found myself tending to do when I was listening to all of us was that we do seem to be pretty good at figuring out what's wrong with Henry and maybe arranging resources to help him. I was thinking more like going back to what happened to you, not so much the what's wrong with you, but what happened to you, just to acknowledge that he's had to endure all these traumas. And maybe it's almost like going back in time, but maybe even recruiting some of those sources to ally themselves to your side. I was thinking maybe we could ask the dad if he realizes what Henry's going through. Maybe we could provide more help for mom, both from an emotional and she has physical disease. How well is she actually taking care of herself? Maybe her grandmother is a resource because someone's taking Henry to church and maybe that's her. So basically going back to his actual story and seeing if some of the other characters in it would be willing to change his story.
Yeah, and I'm glad that you bring up the, what's happened to you because, where the mom might be frustrated that he's staying up and playing these video games. Well, maybe that's his way of coping, right? And sort of helping them bolster their relationship for one another, coming to terms to understand, why he might be having some of these reactions or behaviors that normally we would say, okay, is this pathological? But instead, what's happening and what are the relationships that we could work on? Thank you. I see Dr. Raj raised his hand.
Yes, just a comment. In addition to all the good suggestions that we heard, one other thing that I think will help this child is to connect him with another child who also is from a similar background, but who is able to cope up with this situation and getting better. By connecting him with another child in a similar situation, by talking to him or her, that also will help the child to cope up with the situation to get better, I think.
Great, thanks, Dr. Raj. Want to see if there's any group that we haven't maybe, or any other breakout 3? Anyone from group 3?
I'm sure people were attuned to which group number they were in.
Yeah, I can.
Okay.
Hello. Hello. Hi. This is Loan. I'm from group 3. So we were talking about maybe mom needs parenting classes to help her to empower her to be a better parent, like, help with scheduling and, just to be more assertive when she tells him what he can do and what he cannot do, like parenting skills, basically.
Yeah. Do you have that at your practice?
You mean well, I mean, in my community, I live in Alhambra. In my community, they do offer parenting classes for residents in the city that I live in. And if anybody want to sign up, it's through a community classes. So if any parents want to sign up, and they do it once a month, but well, it used to be that we go there and it's a whole class, but now it's done online. So anybody who has problems with or needs more information or want to learn how to be a more effective parents, then you just sign up, and then it's a 12-week session, once a week, 12-week session. I went to the whole course, and I found it to be very, very helpful. Maybe it will help this lady if she has that kind of opportunity.
Right. And then along those lines, I know Nancy in our breakout group 1 also had some things that we wanted to implement for our kiddo.
Well, one thing I think our group talked about was we identified some resiliency skills. We felt that he had some hope for the future and that he had plans. He was taking a lot of joy in his games, and he was really good at expressing himself, which we identified as a good regulation skill. And then we talked about maybe getting him into some kind of a coding class to take advantage of his plans for the future, and just to try and give him something good to do instead of just playing games all the time.
Yeah, and I think many groups have related the same notion that yes, he would benefit from getting into behavioral health, and then there are also some other skills that we could help for this patient and their family too, both for mom and for Henry.
I don't know if I can see from breakout room 5.
Great.
I personally think, yes, we all talked about where we can refer rather than starting from home. I think we need to educate mom as a pediatrician that let's give your child a good schedule. Let's make sure there is a good enough food at home. He has a schedule of school. He has a schedule of church, what time you go to church. Make sure there is a good sleep hygiene. Is mom going to the doctor? We can take care of all these questions in the office and make sure mom is able to provide some basic care about dropping him to school, picking up school, who takes care of the homework. And so once we don't know if child has a routine, we don't know if child is able to do all that. And then rather than because it's hard to refer out, as I said, in the private practice to all these people, by the time the school counselor takes care of it, it will be another month. By the time we refer to psychologists, mom doesn't have a car by the time. So I think if we tell them that, okay, if he has a good schedule, let's get him to sleep at 10, get some fresh sun for an hour, or playtime, riding a bike, joining a soccer team or something. Of course, it's COVID, but I think basic, the regulation first, if there is some regulation at home, he will be able to do so many other things. Because we haven't addressed the basic issue of sleep and exercise and food. And we are trying to refer him everywhere, which I'm not sure if in all community, we have resources.
Yeah, and we think back down to, the whole point is to help dampen down that stress response and try to reinstill that safety piece. And we know that routines can face safety for kids.
Yeah, that's all.
Hi, Christine. I'm talking from breakout room number 6. We had touched on some similar themes to that. Then one of the big challenges, except for a child like this who screens positive for moderate to severe depression, even with private insurance, can be very difficult to find a child therapist or even a psychiatrist who's willing to see the kid. So that's an identified need of something that needs to be easier for parents to kind of be able to figure out who are those people with openings and who have insurance who are willing to see the children.
Yeah, bridge those gaps. In the couple minutes that we have left, breakout groups 8, 9, 10, anyone wants to report out? Maybe I'll start with breakout 8. I don't know who the facilitator was for that.
And I think we might have only ended up with 7 breakouts. Is that correct, Was?
Yes, we only had 7 rooms.
Great. I will take the last minute to let Dr. Osei maybe comment on what she did in her clinic. This is one of her continuity patients.
Hi, it's been so reassuring hearing everything you said, because I'm like, yay, I was thinking straight. I'm like my colleagues. But basically everything that has been discussed here is essentially what we did for this child. I like to point out the fact that all of this history did not come in that first visit. It took me several visits for me to get this history. I had to earn that trust from this family. So it took me some time. The background story is that mom herself was exposed to a lot of violence when she was growing up. There's a history of substance abuse in her family. And so she grew up under a lot of adversity as well. And so you can see how it's kind of playing into her child's life. And for this boy, one of the things we did right away was the routine, right? Bedtime, meal times, limit screen time. We did those basic things. I would add that we did things concurrently. So we're doing routine and also referring out. And one of the things that I was able to do was start him right away on antidepressants as we waited for the referrals to kick in, because I was really worried about his suicide risk, because I did see a journal that was very concerning. So we were doing things at the same time. I also got in touch with the school. We all talked about that. He has an IEP. I do show up for his IEP meetings because I needed the school to understand that this is a kid who's been exposed to trauma, so learns differently. And so because of that, he has therapy support in school, and he now has in-home services as well. So they actually send somebody to make sure that he's getting stuff done, because it's really difficult for mom to keep up because of the disabilities and how differently able she is right now. So we also reached out to dad. I had to call dad and say, hey, dude, your kid is missing you. Are you going to be involved in his life or not? Right. And so we did get dad involved, and he does show up at IEP meetings, and he is supposed to call his kid every week and find out what's going on in his life. So we're still working on this. It's not sorted out, but I think the key here is that please do not get discouraged. You always have the tools that you need most of the time. As I think she's gone, I can't see her anymore. Start from what you have. And for me, the big thing was she showed up for the visit today. So that's a big positive, right? And she kept showing up for her visits. And so that was where we kind of kept building the confidence for this mother that you can do it. We're behind you. Let's do this together. So just a quick overview. There's so many things we did, but just a quick overview of how we handle this in my practice.
One other quick thought is with the if we could get him into exercise program, then we could hit the social connectedness, we could hit the obesity, we could hit the depression, all with a really good exercise program.
Except they live in a place that's not safe. So that's the other challenge that we have. So then it becomes, okay, if you're playing video games, let's get a dance game and have you dance, right? So like you want to do this, and then there are 15 other obstacles that come your way, and you're like, where do I start? So there's always a wiggle, always look for the loopholes is what I keep saying.
Yeah, it sounds like a lot of motivational interviewing too, to sort of see where you guys could come to the same terms. Great. Any other last comments in the last 2 minutes we have?
Hi, this is Maureen. I was just trying to put this in the chat. I don't know if it went out. But what I often find with these young preteen and teen males, when it's so great that you were able to get the father involved, but I've had so many families where the father is not available or present in the family. And what I try to do in those situations is examine with the young man and the parent, are there other male role models that we can try to engage? It could be a teacher, a coach, a minister. Obviously, he was very close to this favorite uncle who he lost, which is a terrible loss and will never be replaced. Obviously, his father is the first person, if we could get him involved, but it sounds like he's more in his other family's life. And I've had some where they're just not involved at all, or the relationship has broken down so much that the young man just doesn't feel like they can trust their father. So it's the idea of trying to get some other male role model. I think it's so important for kids this age. it's great that he has his mother and grandmother, but I don't know. I just kind of feel like they need to have somebody who can kind of show them the ropes, take an interest in them.
Okay, great, everyone. That takes us up to the 5 minute. So I'll hand it back over to Tina, who will give us some closing remarks and in addition, more information about that survey.
Well, thank you everyone for attending. We're so pleased that all of you were able to join us today. Again, this series was funded by ACEs Aware, as you know, as part of a statewide initiative. And as such, we need to report participant feedback. We would very much appreciate if everyone could complete this post-session survey. The URL is here on the screen, and we'll also post it in the chat. And if you're obtaining CME credit, please make sure to complete it as you're required to do so in order to receive the credit. The survey link in the meeting packet will also be emailed to everyone here on this call, and information about CMEs will also be emailed to you. All right, and this is the first of a series of 4 peer-to-peer learning sessions that we're really excited for SPIVLA to be working with AAP in convening. So for our next session, it will be on February 11th. Dr. Adam Chickendance, who's been the facilitator for this evening, the moderator for this evening, he'll be presenting on how healthcare practices, systems, and policies are evolving to better address childhood adversity. So please go to this website. Please go to this website here, the AAP ACEs Aware website, to register for the second session, and that website will also be dropped into the chat. And again, thank you so much, Dr. Tang and Dr. Chickendance and all the facilitators in the breakout groups today, the pediatricians that are members of the AAP Chapter 2 ACEs Committee. Thank you all for your time and calling in this evening. We really are pleased that we were able to convene all of you together tonight. Thank you.